Everyone will
Great.
get. So welcome to the health literacy training. You will get a link after this session's over, probably later this evening or tomorrow, to this actual recording as well as the slides. I'm Dr. Carolyn Custer. I'm the project director for this Wayne County Health Catalyst Grant. I'm the project director of the training itself. So I will be doing this with my excellent colleague, Maya Campbell.
Well, thank you. My name is Maya Campbell. I am here with MISHWA, so Michigan Community Health Worker Alliance. I'm also a community health worker.
Okay. So the agenda today, we'll go over health literacy, then we'll go over 5 health literacy interventions, take a quick break, come back and talk about specifically vaccine hesitancy in the COVID-19 vaccine and some strategies to overcome that. And then if we have time, we have an interactive case discussion. The learning objectives, describing health literacy as a determinant of health, and then identifying evidence-based strategies to improve health literacy in our consumers and clients and in our community. So specifically, we'll touch on a few, but looking at cultural and linguistically appropriate services and strategies for culturally competent care. And then, of course, understanding causes of and strategies to combat or mitigate vaccine hesitancy. If you want to ask any questions, please feel free to just go ahead and ask them, or if you'd like, you can put them in the chat box and Maya will keep track of that.
Yes.
Hold on one second. Hello? I think anyone's knocking on me. I don't know. Yeah, that's fine. Okay, so, I think everyone in the room has, well, I don't know, may have seen this. So we'll start with talking about health equity. We can't talk about health literacy without talking about health equity. And traditionally, we've talked about the definition of equity and comparing it to equality. And equality is, as you can see on the boxes on the left, every kid gets the same size box to help them see over the fence. But we see equity on the right, where everyone gets the boxes that they need in order to see, right? But we're going to take it a step farther, and we're going to talk about justice and the concept of social justice, which is what we all are trying to do. But really looking at how were these systems built in the first place? And we know that they were built with systemic inequity. And then how do we address those causes so it's equitable without. So I'm going to go ahead. Oh, no, I'm going to do one more slide, then I'm going to turn it over to Maya. So we're talking a lot about social determinants of health, which I'm sure the 3 of you are aware of. These are the things that impact our health that are related to where we live, where we work, where we play. We know that healthcare, maybe 20% of it's what a doctor can do in the office. The other 80% is all of these other things that can impact health and the ability to be healthy. So I just pulled out some of these to give some examples. All right. So Maya and I apologize. It's been a month since we've done this. And this is probably my slide still. Yes.
No,
it's you. Okay, go ahead.
Okay, great. Thank you so much. So what is the health disparities? So the CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunity to achieve optimal health that are experienced by socially disadvantaged populations. Okay, we can go to the next slide. They exist because of health inequities and factors like social determinants of health, and of course, systems that are designed with structural racism, and which we'll dive a little bit deeper into here soon. Okay. So health literacy in Wayne County. Okay, so historically, Wayne County, is everyone familiar with the term redlining?
I am.
Okay.
Yes.
Okay, so as we know, redlining did certainly impact the quality of life of certain populations or certain areas of Wayne County, their access to health and hospitals, as well as education. So what does health literacy mean? Does someone want to unmute and tell me what that means to you?
Is it the ability to understand and make choices related to health on an
Oh,
individual
absolutely.
level?
Absolutely. That's a great definition. Absolutely. Does anyone else? I know I saw another person come unmuted. Does anyone else have anything to add to that?
Abdul
Is that
Rahman
just
did it very well, so no, I'm good.
okay? Okay. So is that just for, are we just talking patients? Are we talking providers as well?
Both.
Both, absolutely. Okay, great. And Dr. Custer, do you want to talk about Healthy People 2030?
Sure, sure. So traditionally, the increasing health literacy or improving health literacy was, on the onus of the patient or the person being served. We talk about, how do we increase health literacy levels? But Healthy People 2030 was unique in that it came out with not just personal health literacy, which is what we're talking about, an individual's ability to understand and use health information, but also organizational health literacy. So how, as organizations, are we actively providing opportunities for individuals to find and use this information? So it really is a group effort. Everyone is responsible for it. So go ahead, Maya.
Thank you so much. So health literacy is built off of a few components, well, several components, the skills and knowledge that are needed to interpret health information. So a patient's literacy and numeracy skills, what is their level or understanding of reading and writing and understanding the use of math and real numbers in the world. Factors that impact health literacy, the complexity of the health information. So how complicated is this diagnosis? Language barriers. As we know, Detroit, fortunately, is a melting pot. So we do have different languages. So we'll get into that a little bit in a different slide. The age of the patient, the state of their health. Are they anxious? Are they nervous during the appointment? And also their cultural backgrounds. And also another thing, a big thing, the way the health information is communicated by the health provider. Is it making sense to the patient? Okay. So this is a graphic of exactly what we talked about, the individual factors, as well as some systemic factors, the public health or system and professional factors, the public health practice, public health infrastructure, and public health workforce. All these things together make up health literacy. Do we have any questions before we move on from this slide?
Okay.
Okay.
Okay, so persons with limited health literacy, they're less likely to use preventive health services, our screenings, right? Our breast mammogram, cervical cancer, vaccination, less likely to effectively manage chronic disease. This kind of it makes sense. It requires a certain level of understanding to be able to effectively manage. More likely to have poor medication adherence, have higher rates of hospitalization and use of ER services, higher mortality rates. Unfortunately, this is common, reporting a sense of shame about their health literacy. So sometimes, and we'll go over some red flags in a few slides, but certainly patients may not want to disclose that they don't understand something. And of course, it's associated with a higher healthcare cost and expenditure. So all of these things are impacts of limited health literacy on the individual level. And then we take it a step farther and we say, okay, what about the community? Because we need health literacy everywhere. We need it at the individual level, the community health level. We also need it in our organizations. So what can that look like? Missed opportunities for services, vaccines, preventive screenings, lack of preparation for severe weather, evacuation, other types of emergencies, missed warnings about things like safety or food hazards, etc. So again, just solidifying the point that we are looking to improve health literacy across the continuum. So health literacy and literacy, the average reading level of adults in the United States is 8th to 9th grade, but most health education materials are written at a 10th grade level. And I think of the 3 or the 5 of us are aware of this. So the best reading level for materials is recommended to be 5th to 6th grade. So there are ways you can check the materials you're using for the readability, and the best is 5th to 6th grade. That's what's recommended. Just again, like I said, some red flags for low health literacy, especially in a clinical setting. Consumers who frequently miss appointments, potentially incomplete registration forms, need assistance to fill those out, non-compliance with medication, just some of these other things. Ask fewer questions. We talk about someone who just nods through a conversation, right? So nodding does not imply comprehension. It's a thing we do, right? So don't assume that because your patients aren't asking questions that they understand everything you're saying. So some of the red flags to look for to identify low health literacy. So using a universal precautions approach is important. This comes from the AHRQ. They have a really nice health literacy toolkit that I recommend everyone look at. There are resources at the end of this presentation. But basically, a universal precautions approach was developed. It's similar to bloodborne pathogens in medicine. So I'm sure everyone in this room has had their bloodborne pathogen training. But really, we can't tell if a person has HIV or hepatitis C just by looking at them. So we assume that all bloodborne pathogens are contaminated so that we can have precautions. And similarly, in health literacy, you cannot tell what a person's health literacy level is just by looking at them, even their education, employment, those types of things, because it may not correlate. So we do use a universal approach, which just assumes that everyone has difficulty in some way in comprehending health information, so that we do need to take all these steps to make sure that our language is understandable. And of course, the goals of using this is to simplify communication, confirm comprehension, reducing the risk of miscommunication, making things easier to navigate. It's so complex already, and really to support patients' efforts to improve their health. And then I'll end this with, the more we normalize, the less we stigmatize. So just assuming and applying the universal approach. And I'm not going to go through all these, but this is what a health literate organization looks like. So it starts at the top, it's incorporated into everything, basically, onboarding, trainings, all of that. And steps have been taken to look throughout the organization and identify areas where increasing health literacy may be helpful. So these are just some of the things that we ascribe to when we're a health literate. Okay, so I'm going to turn it over to Maya.
Great, thank you. Okay, so does anyone have any experience with working with patients or clients that have had low literacy, or even a loved one, or low health literacy, I'm sorry?
Yes, we did. Of course, this is some things that being bilingual caseworker or staff, this is the most things that we recognize that we need in order to deliver the correct health information or required information through our programs to our clientele, because we did examine, there's a lot and high attention need for to be bilingual, for them to understand the health system and the services that they really need. So yes, we do deal with with the clientele on a daily basis that really need health literacy and having low health literacy, actually.
Low literacy, okay. And if you don't mind me asking, as an organization, how do you get over that barrier? Like, what tools do you use to get over that?
Honestly, we always make sure that we translate the information that we provided for them. Like we have the English, but for always we have to have their second language, which is most of our clientele now are from the Arab community. So we do translate it to Arabic. And even if we do go outreach, I'll make sure that we have a bilingual staff. So in case in the outreach, they have a questions that they need more information about through their own language. And another thing, so even with text messaging, like now we're conducting and we're using actually an app to remind our staff, our clients about the Medicaid unwinding. So this information, we don't want a clientele who have a state Medicaid insurance to be shocked about this information or not understand it, because we did experience before when the special enrollment of Marketplace, it was there was a message that's only English to them, and they translate it totally different when they read it, and people start coming, and it was only like acknowledging information that the open enrollment is coming soon. So just of that, they thought it's the deadline now and this is coming, and people start coming. So seeing those scenes make us recognize that we need for sure keep up with the population we serve, with their on with culture sensitivity, with their language needs, and so on. So all our material or the approach we use, like I will send the staff for a community that's need different languages, like I will send my bilingual staff to do this outreach or to collect the surveys or so on. So this is most likely the technique we've been using, and actually it's working. That's why we have a high volume of clients attend in appointments because of the bilingual availability we have.
Oh, wow. Well, thank you so much for sharing that. That is very powerful. Not only is that helping communicate messages to patients, but it's also building rapport. So we'll get into that a little bit more into the presentation, but thank you so much. That was very powerful. Okay. Next slide. Okay, so we're about to go into some health literacy interventions. These evidence-based interventions are strategies that can be used to increase clients' health literacy levels, and it creates a more health literate environment. Okay, so strategy number 1 is clear communication. So all of these are very important, but I love clear communication, as just mentioned in the example. Greeting the patients, using patients' words, showing graphics. I'm a visual learner. I love graphics. So those are very powerful. Making eye contact. And also, I think it was mentioned in the last example, the cultural sensitivity, knowing your audience, slowing down. That is a big one for me. Slow down to make sure that the information is being effectively communicating and received. When possible, demonstrating how things are done, listening carefully. Another one, encourage questions. So I think that by setting a warm environment, by greeting the patient and making eye contact, it will make them be more open and encourage them to use questions.
And you said eye contact twice, so I am going to say we do address some cultures don't appreciate direct eye contact. It depends. So we will touch on that.
Yes.
Oh, we have a question.
Oh, yes.
Oh, Rawa, do you have a question?
I think you're muted.
Oh,
yeah, sorry. I just wanna one of the clear communication that you have here, use plain non-medical language, and this is very important for one reason. I experienced that myself. I'm an immigrant myself, and I used to live in California and the state of LA. It's like all of them, English speaking. There's none around me, and so I used to have the English language, but a little bit, not that much as now. But so when I used to go to the doctor and use the medical term language, honestly, it's like Dr. Caroline was describing me when I was nodding my head as I'm understanding, but I'm ashamed to tell them I'm not understanding anything. I was like, feeling like, oh, I don't want them to think I'm not understanding. So I used to nod my head and then go back to my home and explain to my husband if he wasn't able to go with me, or explain to my in-law, okay, they said this, what does this mean? So this is very, very, I used to have this situation and it did bother me a lot. And that's why I'm very careful now, even with the big words. If I use it I will never use big words with a client. I will use it as the most simple dialogue, because this is really, really, it make a big difference of how we we take in information, especially for people with low health literacy.
Yes.
Sure. Thank you so much. Thank you so
Mhm.
much for sharing that. Okay, so I think, all right. So 7 things to consider when communicating about health. The number one is trust. Will the person trust the information that you're giving? Who is the best source to put that information out? And I'm sorry, I don't want to mispronounce your name. Rolla, yes. So you mentioned that when your organization does outreach, you send your bilingual staff out. That's a great way to communicate that. That is building that trust and that rapport. Information is the number 2 point. What information is necessary and how will people find it? How much is enough information and how much is information overload? Motivation, how relevant is the information? How relevant is the information to the people you're trying to reach? And I'm sorry, Carolyn, Dr. Custer, we're supposed to split this up. Do you want me to keep going?
You can go ahead and finish this one out.
Okay, so environment, what are the conditions that surround that affect the audience? Capacity, is the person able to, or does the person have the ability to act on the information? Are there any barriers? Perspective, what will the audience think about the information and what will inspire them? This makes me think about a patient that I had really quickly as a CHW. She was a grandmother. She did not take her diabetes seriously. She didn't want to hear about diet. She didn't want to hear about exercise or testing, but she loved her grandbabies. So it was, trying to switch that perspective. You have to be here for your grandchildren. We have to start taking this testing and diabetes seriously. So perspective, and response. How will people respond? What can you do to stay engaged with them and give them the support to take action? Okay, thank you for that.
And just like you were saying, using plain language is so important. So again, this is just some of the few examples of things that we try to avoid. Words, we always talk about hypertension, high blood pressure, but the thing that always jumps out to me is the word diet. Because if you ask someone, what diet are you on? They'll think you're talking about Weight Watchers or Atkins or who knows. But really what we're trying to say is, what do you actually eat? So, just being very specific about what you're trying to ask and using plain language versus, especially words like ambulate. Do you ambulate what? Yeah. So, okay. Oh, and here, my next slide. So, another example of using language correctly. I had a situation where we had a person test positive for COVID, and they thought that was a good thing because positive is a good thing. So we ended up saying, you have COVID or you do not have COVID. And that was what we needed to do. So plain language, clarifying, just to the point, right? Less confusion, clear messaging. All right, so, we know communication is so essential. And along with that is using that health education materials effectively. So we're going to go through that right now. And like we said before, materials should be easy to read and understand, aim for the 5th to 6th grade level. The purpose of the handout is clear. You want to have clear messaging. COVID is so tricky. We already know that, but clear messaging, and try not to have irrelevant information. Too much information is overload, like Maya said. Of course, like I just said, avoid medical terms, breaking up material into chunks that make it easier to understand. Using materials that identify at least one action item, so a call out, and using visual aids effectively. And the last thing is beware of confusing numbers. Statistics can be really confusing to people. So let's go through what we're going to do now is thinking through some of these things that we just discussed. We'll go through some materials and we'll have you guys evaluate. So the first set of slides, these are all flyers that were made to vaccinate children. So the one on the left is an MDHHS, the one on the right is the CDC, and the one in the middle is an authority health flyer that was made for one of the health fairs we did. So, as far as the main message, when you look at these three, what do you think about this one, the messaging on this? Which one is most effective, do you think? And why?
The middle one. It's cute, it's eye-catching, the message is very clear. There's a call to action.
Yes. Thank you, Lisa. That's all true. And that's why I always wanted to use this flyer. The CDC one has a lot of little words. There are pictures. There's pictures here too. I think the pictures are okay of kids, but this is very clear. Any other thoughts on this? Okay, let's look at the next set.
I think I just want to add that the age, it does help. The age, specifying the age, it's like more direct message
Mhm.
that make people more understandable and not wondering so much about ages.
Mhm. Absolutely. All right, so this one was developed by MDHHS, and I personally don't like this, but we're going to look at it. Would this change anyone in your clientele's minds? The words like, decades of research, months of clinical development, diverse volunteers, science, does this convince people in your populations, or would this not work so well?
No,
Actually, they won't even look at it. To be honest with you, they won't.
Right. So again, this is not effective. Next three are overlays, so I apologize for that, but these are all MDHHS releases. And the reason why I wanted to show these is, we talk about clear messaging. Anytime you have to put multiple asterisks into a message, you're looking at a potential for confusion. Unfortunately, COVID was confusing and has been confusing as we learn as we're going. But again, this was one where there were multiple asterisks, started to cause some confusion. This one, I still have people calling me, this is the one where you stay home and then you go back to work, but maybe not, maybe. I had friends of mine whose kids were like supposed to go back to work on day 6, but they're still symptomatic. So are they supposed to go back or not? And again, with these two asterisks, it could have been clearer, I guess. And these are just some examples of potentially not as clear as they could be. This one as well. What do you think about the big headlines versus the smaller print?
well, my eyes just glaze over because there's too many words,
Mm-hmm.
and I'm, well educated, high reading level, but it's like too many words. The points could probably be there by themselves.
Mm-hmm.
They don't need all these other informations. I mean, you could have other supplemental information to explain it, but you could have these 4 boxes with just the headers.
Yep. I agree. Okay. Small group, so we'll keep moving. I'll turn it over to Maya for the next 2.
So what are our feelings about this flyer? This is a MDHHS flyer. So this would be something that we would see hanging in a doctor's office, a health department. Knowing what we know now from what we've learned in the presentation about the reading level and our population served, would this be effective?
No.
I think it's a beautiful flyer or information, but it's a little high level. It's a little high level, I have to say that. Super cute kids, some scary pictures here with the baby crying.
And it's
So, yeah.
like you said, it's like, yes, it's probably for specific population or level of education. They will understand it. There will be more like interest in continue reading it. But the main purpose of health literacy to reach out to those have low health literacy knowledge. So in order to consider our message, it's gonna be conveyed to those populations of those clientele. This message is not gonna do the job. I mean, the more direct information that can the level, that's the best example, the level of a grade 5th to 6th grade. If we can do it this way, I think that's the best way of delivering a knowledgeable and useful information for people to use and keep remember themselves, to direct them the right way, but with their own, through their own language, through their own understand of knowledge. But this one is, I think it's too much information to read.
Much information. Yes, it's very dense. Okay. Anything else? Oh, yeah, we can go to the next one. Oh, we can go on to the next one. So how do we feel about this one? And I just want to throw out there, these two slides are showing the same information. So this one is from the CDC.
I won't read it. It's too much. Even though I understand it, even though probably it's gained a lot of knowledge, but actually I'm not gonna be just being busy reading this. This will take me how long to read all of it? I can search probably bullet points and understand it more than to me to sit and read all this information. So
Sure.
this is how I
Yes.
felt.
Yeah, so they definitely look different. I mean, I guess if I had to choose between one or the other, it would be maybe the first one, maybe the MDHHS one. It's broken up a little bit more. It may be a little bit easier to highlight some things, as we mentioned in previous slides, when you're giving health information, maybe circle some information that's pertinent to the specific patient. But both of them, you're right, they are very dense. So we'll move on. Let's see.
One thing that I experienced myself through my program, that the second program I oversee is the Navigator program. When we started saying, okay, no, it's time, we need to let those clientele to interpret or translate some of the information about the state Medicaid benefit, the Medicare benefit, and the ACA benefit, but through their own language. When we had it in English, we had it like, it was like when I send it to communication, this is the information I need. And it was like just written information in a way, like all information on top of each other and so on. So my discussion was, no, I'm not going to use that. If I want to use that, I can print it from my own printer and give it to them. They're not going to understand it. They're not going to read it. They're going to throw it out. So I decided to do it as you know, as a card, hard card, but the card that they can be keeping in your wallet. If you encounter to read something and you don't understand, or let's say you went and you want to know your right about state Medicaid, what it is, like a free services such as under preventive services and so on. So we divided those sections into small. We put a little bit of a label. We labeled everything in a symbol that like has a meaning to the sentence that they're reading, in case reading did not catch their attention right away. At least with their vision, they go to the symbol that does show or indicate that's a Medicaid and that's a Medicare and that's an ACA symbol, health insurance. So those things make a big difference. And the smallest, we decrease the information in a way that's very straightforward and stay in the pocket. If you see the difference of how much people did ask about those cards when we translate them, of course, in Arabic and English, and I said, this is how much when you know your population, it can lead you. Your population can lead you to what's the correct health information or knowledge you can give it to them by you, of course, knowing their culture, sensitivity, being more aware about them, being like working with them more and more. So it does help a lot, but keep stubborn on materials that gonna be thrown away in a garbage. It's not effective at all, and they're not benefiting no matter how much they're trying to send those information.
I love that. Thank you so much. So, oh, wow, you're dropping gems in the training today. So the use of graphics and saving, oh, I love it. Thank you so much for sharing that. So we'll go to the next slide. Using health materials, don't assume the patient can read the material. From what we know, some of the literacy patients may not always let you know that they're not understanding. So just don't assume. We'll use those universal precautions we talked about. And when reviewing a handout, we want to circle or highlight the most important information, because the reality of it is sometimes the information that we have or the handouts we have are just those handouts that we have. That's the information that we have to use. So circling and highlighting those key points is important. Personalize the information by adding the patient's name or medication. Use of teach back. So if you're not familiar with teach back after today's training, you will be, because we'll talk about that very soon. And emphasize the importance of keeping the material so they can refer to it for upcoming appointments. So make sure the patient has internet access when recommending digital materials. I love the use of apps and things like that, but we have to make sure that our patients have access to those things before we're assuming that. And obtain patient feedback on materials.
All right.
Now, over.
Thank you, Maya. Okay, so we'll go into teach back. Any questions so far on communication or health materials? Okay, so who in this room knows what teach back is? Are you familiar with teach back?
I am.
Okay, you know what, you are, the other two, you just don't know the name of it, right? So and this is why we do what we're doing. So studies have shown, 40 to 80% of medical information is unfortunately forgotten, and almost half of what's remembered is incorrect. So one thing we can do as a strategy to improve understanding is teach back. So what is teach back? It's just a way of checking understanding by asking a patient to explain what you just told them in their own words. It's important to make sure that you're not pimping the patient or quizzing. It's not a quiz. It's just a way to really ensure that you as a provider have communicated clearly. So the onus is on you, not the patient. It's a way to check for understanding. And if needed, you can restructure or re-explain and check again. And why is it important? As we know, it's been shown to improve patient understanding and adherence, decrease callbacks, canceled appointments, and improve outcomes. So some of the elements, and we go through motivational interviewing a little bit later in this presentation, and these are kind of the similar type of elements, but using a caring tone, a voice, and attitude, making sure that you have comfortable body language and appropriate eye contact. Of course, our plain language, like we talked about, and using those print materials to support the learning. And then, after you presented the treatment plan or the instructions to the patient, you can ask them to explain back using their own words. And again, like I said, emphasize your responsibility is clearly on you, and document your response. And along the same lines as motivational interviewing, you want to use non-shaming, open-ended questions rather than yes or no, because did you understand that? Yes. That just puts us right back in the same place, right? So asking it in an open-ended way. And then here's just a quick graphic to kind of show how it works. So you're going to chunk and teach the information. And then when you're done presenting, you'll ask the patient to teach back in their own words. And of course, if they're able to, then you've done your job and they can follow up. If not, then you can reteach using different words. And just kind of go with it until the patient has a basic understanding of what their treatment plan is. Next steps. So we're going to do an example. I'm going to be the healthcare provider, and Maya's going to be the patient or client. And so the next few slides you'll see as we go through the next few slides are going to be in lieu of a handout. So imagine these are all part of a handout that I'm going over with Ms. Campbell. Okay, so this is on Paxlovid. So Mrs. Campbell has been seen and has been diagnosed with COVID-19. Mrs. Campbell, as you know, your COPD and diabetes put you at a higher risk for developing severe COVID-19. I'm going to prescribe you the antiviral medication for COVID called Paxlovid. This is what a dose of Paxlovid looks like. There are 2 pink pills and 1 white pill in each packet, and here are the medications that they actually, the names of the actual medications. But the most important thing to know is 1 dose is 3 pills, 2 pink and 1 white. And when you take them, you have to take the whole packet 2 times a day for 5 days. All right, so here's some additional information about taking Paxlovid. I've highlighted the most important things to remember. Don't remove the blister or the pills from the blister card until you're ready to actually take the dose. Swallow the tablets whole. And if you miss a dose, you're not going to want to take 2 at the same time if it's been more than 8 hours. If it's less than 8 hours, you can take the dose as soon as you realize that you've forgotten it. And here's a list of medications that you cannot take with Paxlovid. Are you taking any of these medications? Oh,
I'm sorry. I am. I'm actually taking St. John's wort.
okay, good. Then I'm glad that we discussed this. Make sure while you're taking Paxlovid that you don't take any of that St. John's wort during the same time, because they can interact with each other. And here are some side effects to look for. Symptoms of an allergic reaction are just like any other medication. Look for these. But the most important thing to look out for is liver problems. So this looks like your skin or your eyes could turn yellow, and you might get itchiness and stuff like that. Okay, so I'd like to make sure that I've explained everything clearly to you. Can you please tell me how you're going to take Paxlovid and what you're going to look out for?
Okay, so each pill packet has 3 pills. I need to take 1 packet 2 times a day for 5 days and avoid taking my St. John's wort while I'm on Paxlovid. I can't remember what side effects to look out for though.
Remember, liver damage is the big thing.
Okay, yeah, that's right. And I'll call you if I notice any changes in my skin or my eyes turning yellow, if my skin gets itchy, or if my urine gets dark. I'll be sure to give you a call, doctor.
Great, thanks, Ms. Campbell. See you in 2 weeks.
Thank you.
Okay, so that's a very simplified version of Teach Back, but again, going through the information, using plain language, and then asking her to let me know, what you're going to do after this. Any questions? Oh, I forgot I had a little circle so just to try to show circling handouts, you could all, I did put a circle over that. Okay, so just like motivational interviewing, Teach Back method is something that you can learn a lot. There are so many valuable videos on YouTube or any, other sources that you might want to look into for more information and more examples. So the 4th health literacy strategy is not necessarily an evidence-based strategy, but just something that I was able to do with our medical residents at Authority Health at the time when I was doing their training. So we actually had a health literacy project in a laundromat at 7 Mile in Van Dyke. And every Saturday we'd go in and the residents would present a topic of health related to their own specialty or interest. And we did it as a continuous quality project. So every single week we met and we said, okay, what worked, what didn't, et cetera, et cetera. And we had some really good feedback. For example, using props was so much more effective in teaching than just not having a prop. So things like those big displays that show the sugar in each drink, I don't know if you guys have ever seen those, but it's like a Coke and a juice and it shows all the sugar in each. That was helpful. Over the pandemic, that project ended, unfortunately, but we ended up picking up for Small Steps to Health, which was a project we were going to do in Narden Park. And basically, the point of this slide is thinking about small step behavior change. Small Steps to Health was 5 different topics: hypertension, high blood pressure, diabetes, activity, nutrition, and stress management. And the whole premise was setting small goals with your patients. So we know, as a doctor can tell a patient, you need to walk 60 minutes a day. That's it, 60 minutes a day, and you'll be better. Well, that's really overwhelming for a lot of people. So let's break it down to a very small step. Like, can you do a 5-minute dance marathon in your kitchen or something, rather than saying you need to drink more water, which can be very, broad. Maybe you just, work with the patient, say, maybe you could drink 1 glass of water every morning when you wake up. That's just a very small thing that can improve health. So I just brought this intervention up to say, setting goals, is setting small goals for behavior change is important. Does anyone have any feedback or thoughts on that? Okay.
I'm sorry. I wanted to just chime in on the last slide, Dr. Custer, to share something. I went through a major weight loss, and I'm not a person that loves working out or loves going to the gym. So the thought of daily cardio was super intimidating for me. However, one thing that I did that I found very helpful, a small change or a small behavioral change. My favorite show is Law and Order. So whenever I'd watch Law and Order in the evenings, I'd walk in place the entire time. So that was my way of making a small behavioral change, which led up to a larger, a huge impact in my health. So I just wanted to toss that in there.
Thank you for sharing that.
Yes. So I'm sorry.
No, that was great.
To join my daughter too, because that's her she's in love with this show.
I love it. So tell her in order to watch Law and Order, she has to walk in place. So
There you go.
Okay. So as we've discussed, very, very wonderful thing about Detroit is that it is a huge melting pot. It is a mix of different cultures and languages. I lived before moving to Detroit, I lived in a small town in the middle of Michigan, and I had no idea how diverse Detroit was. So that's the beauty. But with that diversity, it's important as health professionals that we are versed in the population that we serve. So we'll begin with talking about class, or CLAS. So what is class? It is culturally and linguistically appropriate services. So this is the framework to deliver healthcare services. It's being respectful and responsive to patients' cultural health beliefs, preferences, and communication needs. And ultimately, it does promote health equity and reduce health disparities. Okay. So some of the class themes, the principal standards, governance, leaderships, and workforce, communication and language, and engagement and continuous improvement and accountability. So this is take a look. Strategies to implement class. You assess the language preferences and language assistance needs. I know that's something that we just touched on briefly at the beginning of the presentation. Knowing those patients' needs, use acceptable language assistance services. Do not use things that are unacceptable. Plan for interpreter services in advance. Provide written materials to patients' preferred languages, as we touched on before. Respectfully and culturally related things, respectfully ask the patients about their health beliefs and customs. Don't assume. Avoid stereotyping based on their religious and cultural background, and acknowledge and address our own implicit bias. So some language translation services do's and don'ts. I'm sure some of us are very versed on this, but we do want to use bilingual clinicians and staff whose proficiency has been confirmed, our interpreter or staff who have been trained as interpreters, or telephone or video language interpreter services. We do not want to use staff who are not interpreters and whose proficiency has not been confirmed. A big no-no as well. I know I worked in a clinical setting, and this was very common, that patients would bring in trusted family members or friends to sit in on appointments. However, we do not want to use this because this does pose a problem for the patient's privacy, and we want to respect their choice. And minors also should not be used. I know that was a big one in the clinical setting that I worked in. Children who may attend appointments with parents or minor children because their English was we don't want to do that. Okay. All right.
Okay. So these, I don't know if you've ever used this resource, but University of Michigan has the MCare guides. This is free and open to everyone. I just bring it up because they have spent some time dedicated to making sure that there's health education materials on all of these different categories and topics that are meeting the 5th to 6th grade requirement, and also are translated in multiple different languages. So these are just some of the languages they're translated in, some of the things. You can go look at the care guides if you so feel, but they do have a lot of good stuff. I will say some of the stuff is just kind of the information. So it's just a like black and white page with words, but written at a 5th grade level. So you can use that information in tailoring your care plan. And this is just, the MDHHS does have COVID vaccine flyers available in different languages as well. And there's a link there. So we're going to go on to cultural competence. And we know this. Religion, culture, beliefs, ethic, customs can influence how people understand health, how they take care of them, and how they make decisions related to their health. And cultural competence relies on the principles of trust, respect for diversity, equity, fairness, and social justice. And if we consider culture, it can help us to make better engagement with patient, making treatment plans that are patient-centered, family-centered, consistent with their values and beliefs. So culture can impact health engagement in many different ways, but we're just going to give a few examples. And again, in Wayne County, we have such a mix of populations that we commonly see different things related to health. Health beliefs. In some cultures, people believe talking about an outcome will cause it to occur. So that can impact whether or not discussion of that. Health customs. In some cultures, family members play a large role in the healthcare decision-making. Roles of women and men may determine who makes decisions. Roles of elders in the family as well. Some religious faith and spiritual beliefs may impact how people use healthcare. Some religions, for example, don't accept blood products. Dietary customs. I talk about healthy cooking all the time or healthy eating, but if we're making recommendations to our patient without considering their culture and the way that they cook and prepare foods, we may be missing an opportunity there. And then interpersonal customs, like we talked about before, eye contact, physical touch. Some cultures expect that. Other cultures find that offensive or inappropriate. It's up to us as healthcare providers to understand the population we're serving and to make sure that our behaviors and methods are respectful. If you have any questions, please just let us know. Addressing implicit bias. I mean, we're all doing this as a society, which is important. We do have unconscious and sometimes conscious bias. We all have our own worldviews of how we're raised and what we believe in. And it does serve, back in the day when we were hunting and gathering in tribes, people that look different were from a different tribe. So we have this implicit bias that's just built into our system. So what do? We learn about it and we recognize and reflect that these biases aren't impacting our level of empathy or manner of communicating with different people. Trauma-informed service. So I throw a couple there. The next few slides are they could be presentations in themselves, but I wanted to make sure and include them. The book here, The Body Keeps the Score. I don't know if you've read it before, but it is definitely something that I recommend everyone reads. Has anyone learned about toxic stress or adverse childhood experience?
Yes.
Okay. Access? Okay, they might be on it. I don't want to. Oh, go ahead.
Yes, toxic stress. It is. Well, it's something that, of course, we understand, but I just wanna probably by your explanation, I wanna see how it can be related to health literacy in this training.
Right. So this is where it's going. It's because part of cultural competence, I think part of treating populations, period, is understanding trauma-informed service. Toxic stress is, our bodies have a fight or flight response, right? And if that fight or flight response is raised because we're being exposed to toxic stress or stressful situations that continue and don't release, you're going to have an increased level of actually cortisol is the one that we worry about in your body, and that will impact your health moving down the road. So it can impact your health physically, mentally, emotionally. And it's just something that I like to include in this lecture, because it's just another level of things to consider when you're working with different populations. Maslow's hierarchy of needs, like I said, all these slides could be a whole lecture in themselves, but this is looking at, we love and would want everyone to be at this top stage, being the best they can be, right? But we have to consider the physiologic and safety. The bottom rows are so important. Maya, I don't know if you want to share some examples.
Oh, absolutely. So just my perspective as a community health worker, it's great to talk to patients about mental health. That we, especially post-COVID, we want everyone to be in a beautiful, safe space mental health wise. But it's difficult to stress to a patient about coming to or scheduling a mental health appointment when they don't have food or they're being evicted. So that's stuff to think about when dealing with our population. Are their basic needs met? Because ultimately, as we see on the pyramid, it's difficult to talk about esteem and love and belonging if I don't have a place to sleep tonight, or I don't have food to feed my children. Those basic needs supersede those other needs by far. So yes, thank you so much.
If you don't mind me, can I comment on this? You see, that's why more explanation and make you go back during the pandemic and what did we face and what did we offer the clients and what they did accept and what they did not, because of health background, culture, and especially when it comes to mental health stability. We tried to approach with our community. We tried the approach asking when we did the survey, like it's a screening survey to evaluate their needs during specifically the pandemic. What do they really need most? We included all of those services, of course, like food, water, did you need help with rent, and so on. We included, did you need help seeing this, like a provider? One of the things that we include mental health. So when or behavioral health, we use this word as a behavioral health. And then before they sign in, what do they need? When they saw, honestly, when they read and we explained what the behavioral health, and trust me, most people did not contact the source, that which is it was access, but in a different department. They did not. They said, no, we don't. We told them, you're not obligated to see a behavioral health, but this is one of the options. They didn't want to. So of course, approaching to those in our community, this is still a stigma to them, that being seen by mental health services, it's a stigma no matter what's your need. Of course, now it's much better than before, if you're telling me no in the community, but there's still some to people, it's a stigma, and they rather cope it with themselves, suffer it with themselves, than being called or stigmatized as, oh no, I'm not crazy, going to see a therapist, or so on, or for treatment for substance abuse, and so on. So this is the steps. I think that's a great content to include it in the health literacy, because we do face those type of clientele that they may refuse really help, and they are in need just because some things may label them differently, and they refuse the services.
Sure, absolutely. Thank you so much for sharing that. And then sometimes I feel our patients, our clients, they feel, if I just get stable housing, I won't be stressed out anymore. I won't be sad if if I'm able to get the uniforms that my children need. So that, yes, I do think that this is important to include as well. Thank you so much for that.
Okay, and this is the pair of ACEs, which I don't know if anyone here knows about Motion Coalition, but Dr. Dietz was the co-chair for quite some time in Detroit, but he put this together, him and his team. We talk about the adverse childhood experiences study and ACEs in childhood, but we need to consider the adverse community environments that we're in, right? So it's just another way to see, graphic to see all the system change that we need to work on and improve. So, the community things that we need to attack and work on is that so you need to have a good community environment to have great childhood experiences, right? So just something to keep in mind. And then creating a trauma-informed space, health literacy, you're going to be any kind of community health work, you're going to be working with people, right? And so it's important that when someone's with you, that they feel comfortable and they're safe. And so that is what creating a trauma-informed space is. And I do a lecture on trauma-informed service with, it's like a 3-hour lecture. And this is just one of the slides of questions. So we're going to go through these and then take a quick break. So, when you're working, and you can substitute trauma for culture. So have you considered the trauma this person has experienced, or have you considered the culture? Are you creating a safe place for this person to share? Do you have any conscious or unconscious bias that you need to consider? And can you even be unbiased about certain things? How does your own background, history, etc., impact your ability to serve the person? Are your actions making others uncomfortable? Are the words you're using respectful and culturally appropriate? And am I actively listening, or am I just talking? So these are just some of the things when we talk about trauma-informed care that we're aspiring to. Any questions on this? Okay. It's break time. We don't have to do 10 minutes if you don't want to, but you want to do 5 minutes?
5 works for me.
Okay, what about?
The same with me.
Okay, so okay, thank you. We'll resume at like 2:18. I can't tell. Yeah, okay, I'll see you back in a few minutes. And we can just give her 1 more minute, maybe. I think just for time's sake, we'll probably just get started with this information, and then she can join back in. All right, so we're going to move on now to strategies to overcome vaccine hesitancy. There was a field guide, I'll show it in a minute, that we'll refer to, but all right, so vaccine hesitancy, I'm a person that always loves definitions, but it's defined as a delay in acceptance or refusal of vaccine despite being available. And we know that this is one of the top threats to global health. And unfortunately, there's few effective strategies to address this growing phenomenon, but that's why we're here. So why does vaccine hesitancy happen? For most of the reasons that we've already gone through, there's a lot of different factors, inequities in the system, lack of effective public health messaging, so confusing messaging, not clear messaging, a history of unethical research involving ethnic minority groups in the past, as well as structural racism leads to mistrust in the healthcare system. Social disadvantages can lead to that. Something we're currently experiencing a lot with the COVID vaccination is the growing spread of misinformation, disinformation, conspiracy theories, social media, etc. Barriers to access. This is, at least in this area, not normally an issue for us, but in other parts of the world. We're fortunate that we're able to get access to most of our vaccines. So just a quick review of the COVID-19 vaccine. As we all know, the primary series was monovalent, meaning it just covered one strain, and that was 1 to 3 doses, depending on the type you received. And then, of course, recently they came out with this past fall with the bivalent, which bivalent equals 2, bi equals 2. So this one covers the original strain as well as the Omicron variant, BA4 and BA5. Welcome back, Raul. We just talked a little bit about the vaccine hesitancy so far, so I don't think you've missed any. Okay.
Okay.
So like I mentioned before, the CDC vaccination field guide, which I have shared with the PAC before, so I think everyone has this, but we're going to go over 2 recommended strategies, and I'll turn it over to Maya to start with motivational interviewing.
I'm sorry. So I absolutely love motivational interviewing. So motivational interviewing is a guided style of communication that does balance good listening while giving good advice. It is designed to increase the patient's motivation and likelihood of the behavioral uptake. It is also based on respectful and curious ways of being with people that facilitates a natural process of change and respects the patient's autonomy. So an example that I gave earlier about motivational interviewing was the diabetic patient that she was not into testing, but her motivation was really being healthy and present for her grandchildren. So that was a great, I had to listen to get that information. So that was a prime example of motivational interviewing. So the next slide, the spirit of motivational interviewing. Collaboration, it's a partnership between the patient and the practitioner is formed. Joint decision making, the practitioner acknowledges the patient's expertise about themselves. I love that because the patient is the expert in their situation. The medical provider may be the expert on the medical and the clinical side, but the patient really is the expert on their situation. For the sake of time, should we go through this entire slide, Dr.
Yeah,
Custer?
we could probably skip through. So the most important thing is we know the traditional way of medicine, and the United States is paternalistic. It was very, I'm the expert, you're the patient, you listen to me. Motivational interviewing is the opposite, right? So we want to talk and listen to our patients and listen to their motivations. So let's keep going.
Yeah. Thank you. Okay, so the next slide is OARS. So this acronym stands for open-ended affirmations, reflections, and summarize. I'm sorry, that was a super tongue twister for whatever reason. Okay, so asking, as we talked about, those open-ended questions. So examples of this would be, please explain to me, or tell me about, or say more, using those phrases. So the affirmations an example of this would be to be sincere. I think that comes across in every conversation throughout life, the sincere tone and actually listening and paying attention does really help build that rapport with the patient. Okay. And reflections, mirror what the client is saying, use some of their own words, and use examples like it sounds like, or it seems, or must be, those phrases, and summarize. So pull together all the relevant information that you discuss with the patient and read that back to them or explain that back to them. That does help build a bridge or transition between topics as well. Okay.
Is this me?
So I'm
No.
not sure. Oh, it's still me. It's still me. I'm sorry. So some motivational interviewing strategies to discuss COVID. Start with open-ended questions that do not assume the vaccine acceptance. A soft start to a controversial topic. Acknowledge the patient's concerns without judging. I think this is a big one. Because there is so much mis and disinformation, it's important to not take a judgmental tone, because some of that mis or disinformation may come from a very respected source. So it could, break down that trust if you say, that's wrong, that's wrong. For all we know, that information may have come from an elder or a spiritual leader that they trust very much. So it's important to acknowledge that, and avoid criticizing the patient's source. Instead of trying to argue against the information, just provide the high quality, factual information for the patient. Show awareness of your status as a messenger, especially people of color or members of underserved communities. That representation is very important. Who we are as the messenger matters. Link the vaccine acceptance to the patient's hopes and goals. So if we can go back to my example that I used about the grandmother with the diabetes, you want to be here for your grandkids, you want to be healthy. This will help you stay healthy and stay present for your family.
Okay, so that was a very brief overview of what motivational interviewing is. And I encourage everyone again to follow up with YouTube or other sources. We're going to do an example, and I'll be the healthcare provider and Maya will be the mother. This is a child vaccine topic, and we're going to do it two ways. The first way we present it is a traditional way based on education and counseling, kind of that paternalistic top-down model. And then we'll do the same interaction with a motivational interviewing approach. So this will just take a few minutes. All right, so let's go first with the traditional approach. Ms. Campbell, it's important to immunize your child. If not, you're putting him in danger. Do you know there's still cases of measles? This disease could be very dangerous. And what about meningitis? It could be fatal, You should update your child's vaccination as he's already late according to schedule. We could do that now if you want.
I don't see the urgency, and autism is way worse than measles. There are more problems than solutions with this vaccine. Moreover, it's completely unbelievable to give so many vaccines at the same time.
Studies have demonstrated there is no link between autism and measles vaccine. The vaccine is safe, I assure you. You should be aware of the information you get from the internet. Giving several vaccines at the same time is safe and not associated with more pain. We should do that now.
Well, I heard something else, and not only from the internet. I do read a lot. And the vaccines are not mandatory, and I can do whatever I want.
Yes, you're right. It's not mandatory, but you're putting him and other children who cannot receive vaccines in danger. The risk of diseases are much higher than the risk of vaccines. If I'm taking this time to speak with you, it's because it's very important.
Well, that's so easy for you to say. Everything is quick. But what if he gets autism? I'm worried about the risk of vaccines, but you don't seem to be worried about the health of my child.
Of course I am, and I'm worried about the fact he could get diseases that can be prevented by vaccines.
I don't think we're understanding each other. Let's talk about this at another time.
Okay, so I adopted the role of an expert, used a directive intervention approach based on argumentation and writing reflex. So this led to the patient not accepting it was an opposition. Okay, so now we'll do it again with the motivational interviewing approach. So Ms. Campbell, what do you think about the advantages of vaccination?
Well, I know that vaccines protect children against several diseases that we don't see anymore. But my child received his first vaccines, but I'm worried that the measles vaccine could cause autism. For other vaccines, I have fewer doubts, but for that specific one, I'm still hesitating.
As you said, vaccines have reduced diseases in such an important way that they're now much less frequent. It's why you vaccinated your child when he was a baby. If I understood you correctly, with the exception of measles vaccines, other vaccines seem safe to you.
Yes, I know it's a good thing to prevent those infections, but about measles, I'm conflicted. I do read a lot of books and a lot of articles, and lots of people are worried about the link between the measles vaccine and autism.
So you find it's important to protect your child against diseases when the vaccines are safe, but you're worried about what you've heard regarding autism and measles. I see that you've done a lot of research in this subject. If you agree, I could give you some additional information for studies on autism and measles.
Oh, sure, that would be great. I want to know exactly what's happening.
In fact, you're right. One study had hypothesized, I would never use that word, hypothesized a link between measles and vaccine and autism, but this study was fake and the author lost his medical license. More than 500 additional studies have been done since that time, and there's been no link found between autism and vaccine. The frequency of autism in a non-vaccinated group was the same as in a vaccinated group. What do you think?
Well, so I'm not crazy to be worried about that.
Of course not. You're totally right.
Well, thank you for taking the time to understand my concerns. I think it's a bit more clearer now.
Okay, so in this example, MI allowed the mother in a non-judgmental way to express her concerns and ambivalence. This was not the ORS, this was an illicit share illicit method, but it allowed me to give some solicited information that the mother accepted. So that's an example of motivational interviewing. Any questions? All right. Again, something you have to practice. You cannot just learn motivational interviewing and it happens the next day. You have to, after I learned it, I remember just practicing on family members even. So let's move on. So the last strategy to combat, to increase COVID vaccine is combating mis and disinformation. And I don't know this question. So misinformation is false, but not purposefully. Disinformation was falsely made purposefully. Misinformation is not correct, but it's an error. You're sharing it not based on a purposeful. I lost my train of thought. Sorry, guys. So we're going to just quickly go.
Carolyn, so disinformation is when someone knowingly shares incorrect information with an agenda,
Yes,
and misinformation is just they didn't know the whole picture.
correct.
Oh, I always use misinformation as disinformation. So that's interesting.
Oh, well, I hope I'm right. Just teasing.
No, I'm glad you cleared that.
Yes. Okay. So again, we'll talk real quick. This is social media. So the landscape in social media, the point of this whole slide is just basically look at all these different places people get their information from. No wonder there's a lot of floating information that might not be accurate. And so just keep in mind that, you know, your patient source could be anything. So really, we kind of talked about this with the MI stuff, but dissemination of factual and easy to understand is really what you should do to combat mis and disinformation. Rather than arguing like, no, that's not true, that's crazy, don't say anything like that, no judgment, right? We just want to provide factual information and use credible sources and understand that that's not going to be, you know, what changes people's minds necessarily, but that's the best way to attack this. So. Again, trusted messengers, you know, celebrities, faith-based, neighborhood champions, even the CHWs and all of us, you know, we're all people that have some knowledge base and can be used as trusted messengers. Just so everyone's on the same page, I pulled this a few weeks ago. This is the information from the CDC on, I'm trying to move this thing so I can see. So as far as hospitalizations, you can see right here, people that are being hospitalized are much more likely to have been unvaccinated than vaccinated. So we're still in the same kind of situation. Whether or not this data will change someone's mind or not, that's, like I said before, but it is important to know. So for example, 30 times higher in unvaccinated adults ages 18 to 49. We look at deaths. So the black line is unvaccinated, and then we have vaccinated and we have boosted. So we're getting to the point where we're getting really good at managing. Well, COVID's less deadly than it was in the beginning, but you can see that with the vaccine, the death rate is basically zero. And so again, these are the COVID CDC data that came out recently, and I encourage you all to review those.
Okay, so we want to maybe open it for just a few minutes of discussion. Does anyone have any experience with someone who refused to get vaccinated because of mis or disinformation?
Oh, I have millions of, like, a lot of experience,
This
which
happens
is
all the time.
exactly. And you know, to be honest with you, I did experience one in the family itself, because when I decided, me and my husband, first in the beginning, even though I'm working in the public health field, I did want to make sure I'm doing the right decision by taking the vaccines. I didn't want to rush to it. I want to, like, observe it more. I want to discuss
Okay.
it more. And I have my son, he's a nurse, and the first thing that worried me, he said, "Mom, I mean, there's not enough research." This is when we start the discussion, why am I taking it and why he doesn't want to take it. And he felt like there's enough research about it for us to make this fast, rapid decision, and so on. So little by little, when I experience or we witness a lot of people that they lost their life, and the suffer of the pain of taking the vaccine and so on, and working more with this population, as me, we were doing through access T-Mobile mobile sites. We used to go from city to city to provide screening, to provide the vaccines, to provide health literacy, and so on. So I took it, and I'm happy, actually. I did have, like, a little bit of side effect with the second dose and the third dose, but at least, like, I felt in peace a little bit, in a way that I'm still have to be careful, but I wasn't, like, nervously careful as I didn't took the vaccines like before. But when it comes to our clientele, yes, this is where the work comes, that we do witness, especially now as we're working strictly with Hamtramck population. And since we starting doing our own health literacy, because, as you know, the grant has been late of providing those information and the trainings, but as we are expert in the field for a long time with access, we do have those trainings before, and similarity, of course, before we start giving providing about COVID. So we are very much familiar with this information. So since we start reaching out to this population specifically, yes, we do still see a lot of people by their responses, how much they were influenced of not refusing to get the vaccine because of this mis or disinformation. It's not because they do not want it, because they're convinced about and sure about their information. No, it's about something they was delivered to them wrong, whether family, whether social media, whether sitting with the friends and talking about it. And they think if one experience with something, it means everyone is gonna be experiencing with the same thing, and that's what's making them fear more and more. And sometimes, you make the things bigger in your head while you are drinking coffee with your neighbor, and the thing, it's like you started with this conversation, it comes like this, and this is how we start how misleading information start influence in your decision. Yes, we did see it a lot, and I know by the clientele responses, and I think Abdulrahman can add to it, since he did work a little bit with this type of with the population, that their responses, it's like you can tell it's because of the disinformation, not because something is logical to have an excuse why they refuse or why the vaccine hesitancy.
Sure, sure. Thank you so much for sharing that. Yeah, this is we'll continue, I believe. I think Dr. Custer said it is one of our biggest threats to global health is this misinformation. I know in some of the circles that I'm in, there is lots of conspiracy theories that this was population control, and even wild things like there's microchips in the vaccines for tracking and things like that. But as we learn from the training, it's important to listen, to people's their true motivations and connect with that. We all want to live long, healthy lives. So we're seeing the deaths decrease, and that's when we can, as public health workers and community health workers, share that information. Here's some statistics, here's some websites, here's some resources to check out, and allow them to do that independently and come up with their own assumptions. Yeah, I see fertility concerns was absolutely.
The biggest
So I think-
challenge I have is people don't trust the information source that we try to give them. They think the CDC and the NIH are making money off this. They don't trust, they think they lie. And I have no answer to that. I just, at some point, it's, this is my 40th year of doing this kind of work, and it's never been, you used to be able to present some places what we consider to be unbiased health information, good statistics, and people would say, oh, at least I'll look into that, or yeah, that's interesting. And now they're like, oh no, if it came from the CDC, it's not true. And your statistic about unvaccinated being less likely to die, there's a whole bunch of people who see it, they can't read, I think, is part of it, or they read one study that said the exact opposite. So at some point, I just have to give up. There are some people where you just have to give up on this, because I'm not sure what else we can do with some people who are just adamant. And I think Maya said it well, their conspiracy theory, and you could be the best motivational interviewer in the world, and I'm not sure you can unpack that one.
I agree, Lisa. But I mean, ultimately time will tell. I have a very good friend that's convinced that we're all going to turn into X-Men for taking the vaccine and have superpowers or something strange. But I think time will tell, with the way the vaccine will play out. But I definitely understand. But I know one of the factors to consider as well is age. So, as we are seeing millennials, I hate to throw us under the bus, but millennials, where we have this challenge everything and question everything, our own independent research. I think that we will continue to see challenges and explaining these things. So that you bring up a very good point, Lisa. So I say don't give up. The information is factual, and it will stick where it's supposed to. So thank you all for sharing. This is a great conversation. This could be a training in itself. I love this though.
All right, thanks. Okay, so I think we're probably going to skip the case again.
It's okay.
Okay, we need more time, I think. So we were going to do a quick case. This is Eliza. She has low health literacy, but we're going to talk about her another day. Okay, because I want to make sure there's time to do the evaluation and get done before you have to go to your next meeting. All right, so let's summarize.
Okay, so in summary, low health literacy is associated with lower health knowledge, poor medication adherence, increased use of ERs for primary care, and increased mortality rates. All of this impacts the quality of life. It is important to use those universal precautions as we discussed, and not assume that a patient is understanding. Just the same, we can't look at a patient and tell if they have HIV. We can't look at a person and assume that they understand. So let's just assume everyone has low health literacy. Improving individual and community health literacy levels can reduce vaccine hesitancy and increase COVID-19 vaccination rates. A final review. Recommended grade level for all written materials is 5th and 6th grade. Health literacy strategies can be used to increase the patient's understanding about their own health condition, empower them to take an active role in their health. Things like clear communication, teach back using linguistically and culturally appropriate materials, motivational interviewing, and combating misinformation.
Okay, this is our contact information. If you need to get a hold of either of us, we're available. And I did want to point out real quick that Mario Maro, Lori and Shauna, and that group are doing a canvassing training for all the different PAC members. They have a flyer that we've developed on health literacy interventions that they're going to be using and passing out to everyone. So the CHWs know what we're looking to track for our activities for the next 6 months. So Shawish, you will get a handout. It'll be sent out to everyone.
We met with her yesterday, me and
Oh.
Rob. Yeah.
Awesome. So you guys got the lecture before the lecture.
Yes.
I'm so
Because
sorry
the
about
game was canceled, that's okay. So that's the reason.
Okay. And then I will put this up, but there is an additional training on health literacy through the CDC. It's a decent training if you want your staff to take a look at that. And then we've also included resources, links to all the things that we talked about today, some of the toolkit stuff. So any questions before we move on to the end of our session today?
No, thank you so much. It was really, really nice conversation and discussion. And there's a lot of things that even though at times we think we know it, but it's okay to refresh our memory and keep using new things and new tools to improve the health literacy, because I think this is the main tool. We use it regardless what services we provide to the client.
Absolutely.
Yes, and thank you so much for the beautiful discussion and the openness. Every training that we do, it does add, it adds different perspectives. So we do really appreciate that.
All right. So like I said, I'll send out a link to this recording as well as the slides. Maya's put the link in the post, in the chat box for the post, and I've, obviously, or you could scan the QR code. And I'm going to stop recording and thank you again, everyone.